I was tasked to speak on neuroimaging, but the EM physicians need to know and order. However, much of my talk has been already covered on stroke neurology by previous speakers, so I shall be still trying to do some justice to it. So, as emergency caregivers, we are often tasked with the evaluation of a patient with acute neurological deficits. So, they may be having a just fall in sensorium, or there can be a motor deficit like face, arm, it can be a paraparesis, hemiparesis, or sometimes it may be a acute vision loss, and sometimes it may be even a seizure. So, we know that most of the neurological insults will cause a rapid evolution of symptoms, and the deficits can be really permanent in some. So, we have to be really fast in diagnosing them and instituting the right treatment for them. So, the neuroimaging helps us to facilitate triage of these patients, as well as to to institute therapies which might be sometimes tissue saving, and sometimes they may be life saving. So, the most common neurological emergency we would be seeing would be the stroke, and we know the ischemic strokes far outnumber the hemorrhagic ones. And the most common investigation which would be ordered in any ER would be a non-contrast CT head in this setting. And when this kind of picture comes, it is no brainer that there is a large hypodensity which is wedge shaped, and it confines to a arterial territory, and it's causing a mass effect and midline shift. Even a novice will not miss these findings. But there would be the neurons have been already lost in this case, and the focus would be shifted to ensuring survival of the patient and not the function. And you might be talking to a neurosurgical colleague who might think that you have to decompress this person. The real challenge comes when the patient has the acute sign and symptom of stroke, but the CT appears to be normal. So, like in this, if you see with a cursory look, the CT appears to be normal, but if you have a clinical localization in your mind, you know where to look in the CT and then compare with the opposite side. So, this side, the right sided basal ganglionic region is having a hyperattenuation as compared to the left side. Similarly, the Sidman fissure is a very important landmark which is almost symmetrical in most of the persons on radiology, and if you find one of the Sidman fissure effaced like here, or the temporal sulci which are effaced, or there is edema, loss of grey white matter differentiation, all these point out that there is something wrong. So, these all are the early signs of ischemia on CT, and but they may be missed. So, you have to have a clinical localization in place so that you know which area to look to and then compare with the other half. Then there are a few well known signs like a dense MCA sign, which is nothing but a RBC rich thrombus in the MCA, and the patient would be having a marked deficit, and there is a hyperdense MCA, though defined for MCA but can be found in basilar also, and the other CT shows the hyperdense insular ribbon sign. So, insula is a watershed zone between the lenticulostriate branches and the M2 branches of MCA, and because of the ischemia, the ATP, sodium potassium ATPase pump loses its function, and there is a accumulation of intracellular fluid which causes swelling up of the insula, and there is a hyperattenuation also. So, once we know that there is a acute deficit and there is a certain sign of ischemia on the CT, then you have to objectify how grave the damage is, and thanks to my previous speakers, the aspect score has been covered already. So, in brief, 10 out of 10 is a normal CT, and as the score goes down, the severity increases. As in this CT, the area of the right MCA encircled by red would be given a very low aspect score, and patient would be having a poor prognosis. And for the posterior circulation strokes, we have a PC aspects, which is again a 10-point score, but the difference is that midbrain and pons are given 2 points each, while the both cerebellar hemisphere, occipital lobe and bilateral thalami are given 1 point each. So, again persons with 8 or more would be behaving well, and up to 6 score can be considered for thrombolytic therapy or thrombectomy. So, this was a tweet by a radiology colleague on X which popped out on my phone. I picked up here. She has beautifully summarized all the CT signs of stroke in this slide. So, although plain CT head is all the thing which you require for initiating thrombolysis in a case with acute stroke and where there is no hemorrhage on CT, and but many centers routinely perform CT angio. It is a beautiful investigation which picks up large vessel occlusion. Also, it picks up the extracranial carotid stenosis and also the status of collaterals. So CT perfusion is a specialized study which may not be available for many centers. Already it has been covered. The only thing is here the color coding is different as was shown by my previous speaker. However, they are depicted on the graph here. The red depicts the flow is a bit higher than the normal. The yellow and green are normal flows, blue and black are the gray end of the spectrum. So the whole idea is to identify which is the area which has already been infarcted and what is the area which can be salvaged. MREs, though there is a general notion that MRE may be not a good investigation for picking up acute hemorrhage in an acute setting, actually it is non-inferior to CT for picking up hemorrhage, and GRE and SWI sequences are very good at that. And when it comes to chronic hemorrhage, it is a very sensitive investigation. So again, the idea is to pick up the diffusion and flare mismatch, and the aspect score can be calculated on this also. So which one to pick up, CT or MRE? There are many centers in the world which work only on the base of CT. Some work on MRE, and some have a combination of both. But CT overall is a faster and cheaper investigation. MRE is overall better if you focus on limited investigations, limited sequences which can be done in few minutes, and you do not compromise on the door to needle time. A small core with a larger penumbra would be having a good prognosis with intervention, while a large core with a large penumbra would be having a worse prognosis because there is a risk of reperfusion bleed. So like in this image, there is a patchy diffusion restriction with a large penumbra. This patient will behave better as compared to this patient where the diffusion restriction is quite rampant. So the next end of spectrum is hemorrhagic stroke, and most common would be like a hypertensive basal ganglionic bleed, which would be a globular or a overt swelling in the hemorrhage in the basal ganglionic region, which might dissect into the ventricles, causing intraventricular hemorrhage. So most of these strokes are caused by perforator bleeds and cannot be picked up by the angiography. So no need of doing a catheter angiography or a CT angio in these patients if you have a picture like this. But the problem arises when there are confounders. So the first CT is the CT which I showed you in the last slide, and all 4 CTs are of MC aneurysm bleed. So caveat here is that all these CTs are having subarachnoid hemorrhage with them. Further, the hematoma would be more nearer to the Sylvian fissure as compared to the basal ganglionic bleeds, and the hematoma may be flame shaped in some time. These patients warrant angiography, and MC aneurysm was cause of bleed in all these patients. However, the other aneurysm like ACOM and distal anterior cerebral artery aneurysms are less notorious, and they can be picked up very easily. Interhemispheric bleed, a gyrus rectus hematoma typically indicate a ACOM artery aneurysm, while a corpus callosum hematoma or a hematoma which goes along the territory of distal anterior cerebral artery would be a DACA aneurysm. So then comes a category which was not discussed, which is CT angio negative SCH by my previous speaker. So like this patient had a thunderclap headache. The only bleed was in the prepontine cistern as well as in the sella, but the supratentorial cuts were very normal. CT angio was negative. Again, here comes importance of discussion. The attending radiologist reported it to be a normal CT angio. When we did the catheter angiography, there was a anterior community aneurysm which required clipping. Then cerebral venous sinus thrombosis. This is only a cause of less than 1% of stroke presenting to ER, but it is important because it affects the young persons as well as the chances of misdiagnosis are very high. Like in this CT, if you don't have any history and it looks to be a traumatic brain injury because the skull is deformed on the left side and there is a hematoma in the left frontal lobe along the falx. CT angiography was done, but nobody tried to look at the CT venogram phase of that. And when we did the MRI, whole of the anterior half of the superior cell sinus was thrombosed. So treatment here would be anticoagulation. So the caveat here is to look for the hematomas which are near to the major venous sinuses or near to the major venous draining channels, and they should not be in a major vascular territory. So these patients should be subjected to venogram also. Neuroinfections. So MRE with contrast is the investigation of choice in these patients, whereas CT is only reserved for picking up hydrocephalus or seeing its progression on later scans, and sometimes CT is helpful to rule out spinal instability. So the three things which will present to us commonly would be a tubercular meningitis, pyogenic meningitis, and a viral encephalitis. So in TB, the exudates are typically in the basal region of the brain, while in pyogenic, the exudates are on the convexity. The herpes has a typically temporal predilection, and believe me, it is not important that there should be bilateral involvement. It can be unilateral also. There would be gyral swelling, diffusion restriction, contrast enhancement may or may not be present, and a lumbar puncture will settle the issue. So here is some uncommon example. So this young factory worker presented with the status epilepticus. He developed seizure just 4 days ago, no history of fever, was loaded with multiple anti-epileptics and was presented to us. We intubated him and seizures were not controlled even with the propofol. The CT was available just prior to admission, which showed a left-sided hemispheric edema and a hypodense connection over convex convexity. Tried to do MRI, but there was too much of artifacts, and with the limited evaluation, it was possible to know that there is an intrahemispheric as well as left convex infection. And as the seizures were not controlled, without wasting time, we took him up for bundle drainage, and there was a lot of pus when we drained it, and it was a case of circular bundle. He behaved really well after the drainage, though the cause crisis required a few months to improve, but he improved well. So, this is a young girl who presented with back pain since few weeks, lupus since few days, and acute paralysis. And MRI revealed that there is a destruction of T12 and false spine. She required spinal reconstruction. So, then last spectrum, the acute transverse. This is the anxiety which will present to us with acute neurological ruptures. Lower limbs are typically affected more commonly as compared to upper limbs, and then you will be autonomic instability. On MRI, there will be T2 hyperintensity and core is swollen up. But the important difference from the other anxieties which can mimic it is the intramedullary region like astrocytomas or ependymomas. Intramedullary tumors, there will be an expansion of cord, but typically the tumor cyst of CSL will be associated, both have upper and lower end of the swelling, while in transverse meningitis it will not be there. So I will wind up here. So the neuroimaging helps us in rapid triage and treatment decisions, and it is important to have a clinical localization before you go on to interpret neurology. And that's I think that I will cover the speaker's speech. Thank you. Good.